Good afternoon, everyone. My name is Steve McGlothlin. I'm product manager for J2 Managed Terminology, and Nick and I are going to spend a few minutes talking to you about the project that we worked on together. Well, his team really did the work, but we're going to take some credit along the way. Myself, I spent 15 years at InterSystems, actually in sales, selling the InterSystems product lines, and the last 4 years working with J2, helping to implement those solutions with customers like Nick. So I'll turn it over to you.
Thanks, Steve. I'm Nick VanDuyne. I'm the Senior Vice President CIO at Healthix. We're the health information exchange for the City of New York and Long Island. I've been in healthcare since '93. Started out as a DICOM engineer and somehow ended up in HIEs around 2005, and I've been in the HIE space ever since. I've been with Healthix by way of a merger. Healthix is a conglomeration of 5 smaller HIEs throughout the City of New York and Long Island. We've all kind of merged into one, so that's had its own unique challenges. But we have a great vision, and I really like to point this out to people, is that our vision is that we're your trusted partner sharing health information to improve people's lives. And I really like to point that out now because what we're going to talk about today really helps us do that better. At least I believe it helps us do that better. Our purpose is we're dedicated to improving the health of the community. We're innovative. We respect people. We all have our mission, vision, and values, but again, I really like to emphasize our vision because that's really who we are, and that's really what we're going to try and talk about today a little bit. Thank you. Next slide. As you see from the map, we're pretty big. There's over 8,000 facilities that we cover. It's a lot of data, a lot of data entry points. We hold a petabyte of data. We've been in this business since 2007, I believe, was the first HIEs that became part of this. So it's a lot of information that we like to share with people, but it creates a lot of problems. One of them that we're going to talk about today is normalization, right? So through the years, as an organization, we were required to get people connected. That in and of itself is pretty vague, right? So it's like get people connected. Then comes the idea of, well, nobody really gives you the information in the same format, the same standardization. So that's kind of where we started with the challenges. And so this is our goal, right? So we have all these reasons that we want to have this data: clinical care, population health, public health, research, and consumer engagement. And again, because we're just the vehicle for the data, and our role is to make sure the data is usable and provides better outcomes for people. And this is just a little quick shot of us. So I want to explain some of this. So in first quarter 2022, we did 854 trainings. In the state of New York, you're actually required to be trained on what the HIE does. And so in the first quarter of this year, we did 854 trainings. We have over 20 million patients in our HIE Master Patient Index. We delivered 36.1 million alerts in the first quarter of the year. Almost 500,000 patient searches. 37.6 thousand users monthly average. So we're pretty active. And this really kind of doesn't give you the whole picture, but gives you the idea of what we do. The records delivered, the alerts delivered, that's all push data out to people who would rather have it themselves instead of looking in the portal. So it's important to get that information right for not only people in the portal, but people who are getting the information from us. So why terminology? So I've already explained, everybody gives you the data different. I get it different from you. I get it different from them. 81 hospitals, 8,000 facilities. We want a better user satisfaction, right? So a clinician wants to look at standard data sets for everything. We wanted it for data consistency. We wanted it for analytics. And we wanted it for US CDI. Now, for those of you who don't know, we're all supposed to be US CDI compliant December 31st, right? It's a very auspicious goal. We're hoping to get there. We're pretty confident we're going to get close. And as an extension of that, we're hoping to be able to tell folks that we can be the US CDI compliant vehicle for our connected participants. So we have a strategic partnership on this terminology project we're talking about. And I'm going to let Steve tell you a little bit about J2. They've been our partners in this endeavor. So, Steve?
Yeah, thanks, Nick. So yeah, J2 has been an InterSystems premier implementation partner since 2004. We've been a strategic partner with Healthix for 15 years, helping with them with many of their HIE needs. But when they looked at the terminology strategies that they were going to pursue, they put out an RFP. And so I'm going to spend a couple minutes talking about our offering and what compelled them to select us for that RFP selection. Health exchanges, payers, health systems, really anybody that's aggregating data from various sources, they do a good job of bringing that data together, harmonizing it with HealthShare. And it's not until they get that data in one place that they're able to analyze it and start to see that there's terminology standardization issues. HealthShare has the ability to natively apply translations, but those mappings must be created and maintained outside of the product. And so when we've worked with various organizations over the years, helped them with terminology, being able to address things like inconsistent codes, local codes that they're receiving, being able to align to a common standard. But the problem historically has been that these are very costly projects, very lengthy in time. A lot of them required very specific clinical expertise to be able to guide the projects and manage the data. So we decided to create something different to try to change the game. So it brought us to introduce J2 Managed Terminology. We brought together a proven platform for mapping automation. We created an effective methodology to assess data and determine a pathway for mapping. And we brought into our organization the clinical expertise to be able to help organizations like Healthix. The mapping is performed in the cloud. No PHI leaves your environment, so it's a very secure environment. It has automation, tunable algorithms, and there's user-friendly tools so that even a non-clinical person like me is able to do some mappings. And so what it really did is it helped reduce the effort and the cost and the time frame to be able to deliver solutions like what Nick's project looked like. So Nick's going to tell us a little bit about what their experience was.
Thank you. Next slide, please. So I just want to give you sort of where we started, right? So again, we consume data from 81 hospitals, one large reference lab, thousands of providers, clinical-based organizations, and payers, right? 23 of our 81 hospitals send LOINC codes, but not consistently. It's a big problem. We also get CPT codes for procedures, but not consistently, and the coding rates, they vary from 10 to 100%. So we had the same issue I'm sure you all struggle with, right? We don't have good data. We don't have good normalization on it. It makes it difficult. For those of you who have gone through any type of COVID reporting, probably early on, we had to throw like 80 some odd wildcards in there to do COVID reporting before the state and the federal government got their act together on it. And we're probably close. Would I say we're 100% accurate? I would never say that. But, the whole idea behind this endeavor was to help get us away from that inconsistency and the ambiguity of wildcarding. So we put together a team. This team consisted of us and our partners at J2. First and foremost, we needed interface analysts, right? Let's look at the interfaces. What interfaces are giving us good data? What interfaces are giving us bad data? What interfaces have good data but in the wrong spot? This is not uncommon. We also had data analysts actually look at the data. Was it standardized? Which ones were LOINC codes? Which ones had proper NDC codes? And then this next group of people, the customer experience team, I can't really emphasize this enough. These are our people who talk to the clients, right? These are the folks who got to go out there and convince the LIS director that, hey, we really want you to start sending LOINC codes. We really need you to partner with us to make this happen. It is probably the most unrewarding part of the project. They're probably the team that had the toughest job, I'm not going to lie, because, you know, they're the ones that meet all the resistance. We had data mapping coordinator. We get a little star by this one, and we want to point this out because you would think that this needed to be a clinical role. And what we found through using the product and through this endeavor and through the whole process, that we didn't need a clinical person to do this. The system itself, the tools, were usable enough to where we could get just a good data analyst to actually take this position, learn how to use it, and function very well within the tool. And then project management, always needed. You know, we all tend to be slackers, so if there's somebody who's, you don't have somebody riding train and, you know, cracking a whip on you, you just, everything's going to slip. So that's also another key role. So this is our timeline, and it's per domain. So we broke things down. You know, rather than try and tackle everything at one hospital at one time, we said let's take it by domain. So let's do labs. Let's do diagnoses. So each domain sort of had its own little mini project kickoff, site-by-site analysis, stakeholder outreach. Again, this is where our customer experience team came into play. Interface configuration and terminology mapping. And again, the terminology mapping is done by us with the tool. Stakeholder sign-off. So this is another key part, and this goes back to the stakeholder outreach. You know, we didn't want to just say that, hey, we've mapped it, it looks right to us, we're good to go. We went back to the stakeholders and said, does this look right to you? These are your codes. These are what we believe they are. Does it match? Are you willing to say we did it right? If not, which ones do we need to change? Do you want to take some off the list? And that was really key for us to make sure we could get that done correctly. And then the validation and deployment and the post-go-live support. Again, this last one is kind of a big deal. You know, you kind of get through a facility, you want to claim victory, they change their lab set, you know, you got to kind of go back. So there's always going to be an iterative process, right? You can't just say we did it once and we're good to go. You want to go back, look, make sure you're doing it correctly, and just reevaluate from time to time. Next slide. So here's kind of our analysis and process. So the issue first is locate the coding standard data in the HL7. If it's present, reposition it into the right place. A lot of times what we found is you get a link code, right, but it won't come in the primary field. It'll come in the secondary field. So you go do your translations, put it in the same place so that when it gets into the SDA, it's always in the right place. Gather local mappings from the clients, right? If you can get them to do the work, do it. That's not necessarily going to happen, but you know, if you can get them to do the work, do it. If not, map the appropriate coding standard, and this is where the system came into play, right? So, you know, put it into the terminology engine, get the mappings done correctly, have your data mapping coordinator run through it, present them back. And then one of the things we like to do is report on our website how well we're doing. I don't like to call it public shaming, but you know, hospitals in New York are pretty competitive. So if you're all green, you can walk around feeling all proud of yourself. If you're all red, you know, somebody in your organization is going to go, why are they green and we're red? And it kind of helps motivate. So if you just take a look at the site, we'll show you here. If you want to click out there, Steve. There you go. So this is our scorecard. And you can see this is our percentage of complete, percentage of compliance by domain. And then as you scroll down, this is by individual facility. So all the greens are good, right? We like green. We like a lot of green. You can see we have some areas of red. Areas of gray is stuff where it's really still kind of, we're working on it. But this is out there. It gets updated weekly. We let our partners know and our constituents know that this is out there and that, this is how well we're scoring.
It's got a transition.
So this is where we are today compared to where we started, right? And this is really we're really proud of this. I hate to use the word proud, pride goeth before the fall and all, but the dark blue is where we were when we began. And I really want you to look at labs, right? This is huge from an analysis perspective, analytics, reporting, labs, diagnoses. We're at 9%, we're at 93% now. 30% diagnosis, 96%. You can see meds, surprisingly, we haven't started working on them yet, but we're actually in pretty decent shape to start with. So that's a good one for us. That's one of our next steps, is to work on meds, work on radiology. These are big deals for us. Procedures is one we got to work on better. You see we got a 61% increase, but still not really where we're trying to be. Our goal was 75%, so we just sort of hit that threshold. If we get 75% compliant, we're like, hey, we feel like we're doing pretty well. We really want to do better. We'd really want to get everybody up 95, 100%, but this is just gives you the visual of, where we started, where we're at. Next slide, please. So we talk a little bit about the platform. Steve's going to kind of give you an idea of how that worked for us.
Yeah, so the J2 Managed terminology is the platform that helped them get these results. It's a cloud-hosted managed solution, so we provide the base environment with all the standard libraries preloaded. We provide the periodic updates to the system and the environment. So Nick's team, all he had to focus on is the mapping. They didn't have to manage the infrastructure for doing the work. We provide all the support for it, and we have additional services that they can, call on when needed. Part of the thing that really helped us drive this so that their results were as rapid as they were was to create a program really focused on driving fast results. We started by analyzing historical data. We would take that historical data and look at where they could have the most impact the quickest. So we put the data into different buckets and would be able to identify the way to process that data based on the type of characteristics that source data had. So we could process different data differently. The platform itself is pretty comprehensive, so that it allows for automation of anything that you can really see, trends or characteristics that you can define. It has the ability to modify algorithms, so for different types of scenarios. Some of the data sources we saw, a lot of times what would happen is that instead of getting a code and a description, they would get description. So we had to figure out mechanisms to be able to map from the description to identify the code that it represents. And so that we could create algorithms and the system could help drive those in an automated way. And then when manual mapping is involved, and Chris knows this, there's tools there that help you look up the different options that are available, what it thinks are the highest ranking or the most probable codes or matches that you should be making, and the tools are there to help you verify and validate that. And then it has the ability to do distributed workflows. So for different team members, whether it's our team helping or across your own team, or even if you want to reach out to an external partner, you can actually put the tools in their hands, so they can be the ones to do the data validation, the mapping validation, or even do the mapping work themselves if that's what you want to do. And everything we do, we take a really HealthShare-Centric Architecture strategy. For this project, and for most, we would encourage the use of late binding. This ensures that all the source data remains untouched, so that the only time transformations are applied is when you're viewing the data in the clinical viewer, or you're sharing the data, or you're sending it off to Health Insight, so that transformations are applied then. That way, if there's changes in the mapping or changes in the base libraries for the ontology, then you can actually have the most current up-to-date mappings available to you. And one of the things we did is we created a synchronization mechanism directly into HealthShare, so that you're always able to present the most current published maps that have been completed directly into the HealthShare transformation process. We've also taken all the steps to make sure that the mapping process and the synchronization process are never going to interfere with HealthShare's operation or the ability to ingest data. Now, as Nick said, all of healthcare right now is really being driven towards US CDI. It's a standardization that has terminology requirements for it. Many groups are also being forced, to support the terminology standardization requirements around CMS or TEFCA. These are designed to make health information more interoperable, more usable, make it more available to patients. But beyond the way that we've talked about how we can work with HealthShare, our platform has APIs and FHIR capability to be able to support Iris for Health or Iris applications so that application vendors that are building solutions can actually also leverage a platform like this to be able to provide standardization and normalization for their applications. So at J2, our goal is actually pretty simple in this process. What we want to do is we want to provide a methodology and a platform that really drives rapid mapping automation. And that's our goal. We have the services to train and mentor your staff. We can be available if you want us to help drive your project faster, or if you have staffing, gaps in your staffing, we can help you do that. But our real goal is to help you as an organization be able, like Nick's organization, to be able to unlock the value of the data that they've collected already so that it's better and more usable. So Nick's going to talk now a little bit about what his future plans are and what he sees on the horizon for the HIEs.
Right. So, as Steve said, US CDI has really sort of been our basis, and we're unique. I shouldn't say we're unique, but New York is a bit unique in the way they tackle things. We actually have to report to the state on data quality on a lot of initiatives. So being US CDI compliant is not only our goal, but we have some actual mandates to meet it. The first step in that actually this year is race and ethnicity. We have to be able to prove that we can provide those at the correct levels to ensure that we're actually meeting race and ethnicity in the way we record it. And not only that we're compliant, but that we up-level it. So, I'll give you an example. We'll get a compliant code, but it's a indigenous Chilean Hispanic, right? So state of New York really doesn't want to know that. They just want to know they're Hispanic and it's the right code. So not only do we have to ensure we meet the right code set, we have to make sure we meet the correct level of the same code set. And we want to assist our clients in US CDI compliance, right? This is a huge project. I mean, I've spoken to probably 15, 20 of our clients and big clients, and they're looking at, well, we're going to spend $5, $6 million this year trying to get to US CDI compliance, but we don't think we're going to make it. So anything we can do to help them will really be beneficial to us, will be beneficial to them. And we're looking to get to that 80, 90% compliance across all areas. To me, it really helps us. It helps our clients. Particularly in terms of research, particularly in terms of normalized data when you're looking at clinical outcomes, in terms of presenting the data back to the payers in ways that they want it. We see this as something that helps us to help them in terms of getting their HEDIS measures. It's a good step. And we want to provide the better outcomes, better set of notifications. As I mentioned in the beginning, we send 30 some odd million alerts. We push 30 some odd million pieces of data out to people each quarter. So for us to have that in a more normalized, standardized code set is great for us. Gaps in care reports. This is a big one for us. We like to generate gaps in care reports, help people understand that, their patient wasn't compliant, right? They didn't get their A1C in the last, 6 months like they were supposed to. And for us, improve analytics and assistant clinical decision support. This, to us, is huge. Like I mentioned, anybody who tried to figure out COVID tests in the early days was wild carding out their butt, and we don't want to be there. I don't want to be there. I'm sure your data analysts don't want to be there. And also to help us in presentations, normalize the way things look in our portal, right? We want the same code, the same lab description, the same diagnosis every time. So it's consistent. The clinician sees the same consistency all the time. He's not trying to figure out, well, is this really the same lab as that lab, 80, 90% of the time they probably can. But you know, when you start thinking about the resident, the kid who's just finished up med school, he's got his first year of residency, you know, think about him when you're thinking about the 80,000 different ways somebody's describing a lab, right? You're really helping him. You're helping him to make better decisions. You're helping him to improve his future. You're helping him to improve some patient's life. And you know, where are we going? I'm sure you've all heard a lot about social determinants of health. To me, it's huge. I think that when we talk about clinical information, we're only talking about the results of somebody's life. We're not really talking about what led them there, right? I could treat a patient for hypertension, but why are they hypertensive, right? Do I know that they can't pay the rent? They're having a hard time paying their rent. So, you know, they have to choose between decent food, paying the rent. So they're eating ramen noodles 6 days a week, sodium-laced ramen noodles, or sodium's through the roof. You know, their blood pressure's 153. It's got nothing to do with the fact that, you know, they're hypertensive. It's got more to do with the fact that their life is kind of a train wreck, you know, and we need to be responsible for that. We're part of the solution. You know, we like to think of ourselves as these sort of nerdy, we got all the data, that's our job. It really isn't. You know, I want to go back to our mission. Our mission is to improve the lives of people. We're a trusted partner. And if I don't live up to that mission, then I've failed. I can have all the data in the world, but if I don't make it actionable and I don't present the right information, I've failed. So I would recommend highly to everyone, you normalize your data, you get your social determinants of health data, and you make a complete history of the patients for the people who need it so that they can provide the best health care and the best outcomes to your neighbors.
So that's it. If there's any questions for Nick or myself? Yes.
And anyone with questions, I'm going to bring the microphone to you if you don't
You
mind.
got a microphone coming for you.
I've got a pretty loud voice. I'll go ahead and use it. So I think I have 100 questions, but I'll start with this one. When you were talking about the 9% where your labs were when you started, can you help me understand what you meant by that?
Sure. So 9% of our labs were LOINC coded, 9%.
Okay.
And so we're at 93% now.
So that means the proper code in the right format and the right structure, along with the proper description that was current and accurate. Many times what we received or what we viewed were, you know, modifications of that or derivations of that. There may be a right code, but an incorrect description or no description. Sometimes a very common occurrence is that there's just two descriptions. Because if you think about how many clinical viewers, including the way that EMRs exchange data, they typically are presenting the description only. They're not presenting the code. And so for whatever reason, when they share data, they're typically sharing descriptions. And that's what they focus on. So by them feeling like they're sending the description, they feel like they're fulfilling the need of the data that's being sent across. So what we have to do is then help them be able to essentially reverse transpose that description into an associated code. So then you can have consistent codes and description pairs.
You again.
Me. How do you do that with the with labs specifically? Just because I mean labs results, especially when it comes to transforming them into LOINC codes, you need to know what kind of machines they're using. There's a lot more than just a description that means something. So how do you do that?
You know, we take this, we go through the descriptions, we go through their coding sets if they send us local codes, and once we go through the mapping exercise, as I mentioned earlier, you know, I think my guy's pretty good at what he does, but you know, the proof is always who's the LIS manager in the facility, you know, give them the list and say, we've mapped it, please confirm it. And they have the option to say, yes, they're all right, or no, this one's wrong. You're never going to get them all. You know, I worked for a large IDN. We had a lab code for brown recluse spider venom. You know, probably not a whole lot of people putting that in their lab set, right? So, you know, the thing is again, as I mentioned, to really be interactive with the client, to get your customer success team, as we call them, to engage and ensure that you've opened those conversations with the clients, they're verifying what you're doing so that you can actually get the correct data, and that they say, yes, this is right, and then you're allowed, then you can apply it.
And you found with labs specifically that they didn't have, I mean, Loink, I mean, I understand them not maybe sending it, just because sometimes, depending on how they're doing it, they might not have it available to send it, but
Right.
not to have an actual crosswalk. You found that they didn't have crosswalks already?
Well, we would
created?
ask if they had one.
Okay.
If they had a crosswalk, we would take that first.
Did you find that you had more that didn't, that you actually had to do it yourselves?
You know, I don't have the exact analysis on that, but, you know, we did start out, like I said, we started out at 9%,
Right.
and now we're at 93, so.
How easy or difficult is it to expand on the terminology that you use? We're from the Netherlands and we use Nomad, we use Loink, but unfortunately a lot of terminology that's specific to our country.
Yeah.
So is it easy to implement those?
Yeah, well, ironically, the vendor that we use underneath the engine we use underneath is from the Netherlands. So, but no, the platform itself can actually use any standard ontology, any standard library. So we can go to NLM, we can go to VSAC, we can bring in subsets or standard published non-standard things like NEMSIS, but they have standards that they publish. We can incorporate those. It's really a mapping tool, and you may have to train it some on the algorithms to understand what the properties are that underlying the ontology or the library set that you're using. But it has the ability to work with any type of library or even custom. So if you do get a client compendium, for example, we can actually ingest that and let the system consume that and learn from it.
Do you have any numbers on how much is automated and how much does need human interaction?
So it depends upon the quality of the data.
Yes.
I don't know if there's a more politically correct way to answer that. You know, and again, it also, if we focus on, you know, the areas we can have the most impact, you know, by focusing on the top 2,000 lab results or the top 1,000 lab results that you see by occurrence, it gives you generally, those are higher quality data, or at least there's more volume of it, so you can build algorithms to, you know, tune to those. But there are certainly outliers. I mean, a lot of the data sets we were looking at were tens of thousands or 100,000+, you know, unique codes and description pairs. You're not going to map all 100,000. You're not even going to attempt that. You're going to try to isolate it down into a bucket of something that is usable, something that's, you know, can be, you know, automated to a point. But for most of the data domains, your group accomplished them in 3 to 6 months for a data domain. And there's, you know, there's the ongoing effort of working with the clients. That was the, you know, probably the longest term of any effort that was involved.
Yeah. If you have, you know, you put your team together, like I mentioned earlier, your interface analyst, your data analyst, and your coding coordinator, your mapping coordinator, you know, and they have the ability to focus on that, it's pretty fast moving. I'm not going to say it's simple, but it is pretty fast moving.
So is there a fire terminology server underneath this?
Yes, there is, or fire capable, I should say. Yes, so it is fire, be able to support, you know, if you have an Iris or an Iris for Health or some other external application that is fire compatible, you can make calls into the system. You can have custom maps, so it can either leverage, you know, standard maps that are published by organizations, which include some cross maps like, you know, ICD-9 to 10, Nomad ICD-10. You know, these types of maps already exist, so it can automatically leverage those. But you can also do the custom codes. So if you had a custom local set, or local code set that you were receiving, you can create the mapping in our platform, and then you can leverage Fire to access it and do the translations.
And the fire operations that are terminology operations are
They're
all
included and
capable,
embedded
yeah.
in there, yes. Yep.
So this is actually the first I'm hearing of US CDI. Would you be able to tell us a little bit more about what that is?
So US CDI is the standards they expect you when you submit data to someone else, right? So your labs need to be link code, your meds all need to be RX norm or NDC. Your CMS, your race ethnicity needs to be CMS compliant. So I can actually, I wish I had it with, I could give you the link. If you want to give me your email, I'll give you the link to all the standard, and you can just look at it. Hopefully, you know, we all like to think that we're there, like it should be a no-brainer, but it's not. There's still a lot of work to be done. But if you want to give me your email, I'll send you the link.
And you said something about there's some deadline by December 31st?
They say December 31st. We're supposed to be US CDI compliant. That may move. You know, I haven't followed up lately, but you know, that's what we're still shooting for, December 31st.
So if your clients are US CDI compliant in this effort?
Well, if my clients were 100% US CDI compliant, I would not have to be going through this effort. Yeah.
Correct.
Right. But the reality is, you know, they're not. You know, we're not, they're not. We're consumers of their data, and the data I have is proof that, you know, they're still on their journey. So.
But even in an environment where everyone is submitting US CDI for some data needs, there still is a need for at least automated mapping, right? So US CDI says you can be ICD-10 or SNOMED. Well, it gets a little more challenging when you're trying to do clinical research cohorts identification, and you've got multiple options for domain sets that, you know, the data can come across. For medications, it can be RX norm or NDC, which NDC is, you know, a little bit more challenging as well. So in a scenario like this where there's other purposes for the data, you want a common standard library. So all of their meds are going to go to RX norm. So all of their, the diagnoses are going to go ICD-10, so that they have a common, consistent domain underneath, or ontology for all their domains.
Are you able to do multiple levels of normalization? In other words, you take the term that may come in as a drug code that is in a drug that is a name brand drug, and you normalize it to its generic RX norm parts, and then you maybe break the parts of
so there are some kind of, right? So the answer is kind of there. Obviously, some of it requires then going back to the data source provider to understand what their intention or desire mapping would be. So there are options. Medication's a challenging one. Luckily, their medication data came across pretty good. So, but the NDC to RX norm, there are a number of standard maps that are sort of industry accepted, and those are easy to automate and bring across. It's impossible to go the other direction, obviously, because you're going to a one-to-many. But there are still outliers, and one of the other things around it that is classification of data. Data's coming across that looks like medication many times is other things. So it actually may be HCPCS that should be mapped to, because it's not really what we want to, you know, be mapping as an RX norm. Even though it may be coming across as RX norm, it probably is better to be standardized as HCPCS or something like that.
Last question, I'll give this away. You guys are doing some work for us now on data ingestion development,
Okay.
Arkansas Blue Cross.
Okay, yeah.
And when you find a code today that is a local code, or it's not coded, then you guys develop a local code to place in our SDA. So you're concatenating some things in the definition, if that makes sense.
That's certainly an option, and that, yes,
right.
that is
And so
strategy.
once that data is in the SDA, is that when this takes place? I guess that's getting into the
So
weeds.
the way HealthShare works is that the transformation of the maps are applied when you either view the data, so that local code and description, if there's a map available for that local code, when someone views it, it'll be transformed to that mapped value. Or if you share it, so if you're going to distribute it to an external entity, then when that distribution occurs, that's when that transformation. The other part is when it goes into Health Insight. So at the time of ingestion in Health Insight, if a transform is available, it'll be applied at that point in time. One of the, you know, the ongoing processes then is when you later, let's say, apply a map a year from now, that now that local code should be mapped to something. You either need to replay that patient record, or you need to have a process, an external process that goes through and updates that stored data, because it's persisted with the mapped value along with the source value. So,
Thank you.
yep. Anyone else? All right. Thank you
Thank
for
you
your
so
time.
much for your time.